I'm delighted to give an update or talk on telehealth as part of core business. So really the areas I wanted to cover are role of telehealth in healthcare under the heading of rationale for telehealth, definition and models of care, Townsville teleoncology network as an example, and also supporting evidence for effectiveness and clinical outcomes, and also touch on a bit on implementing telehealth as core business and establishing models of care, and then touch on at the end doctor-patient communication on telehealth. So the reason why we talk about telehealth is because of the issues faced by rural, remote and indigenous populations, and also faraway places where health access is a difficulty. So in this picture, you could see the travel issues faced by patients from rural, remote, indigenous to access specialist care in tertiary care or larger centres, long travel distances, the cost associated with this, and the inconvenience of relocation. And also, the rural workforce is still in shortage, skills are problematic to maintain, and specialist support is limited. And it's really confounded by the disparity in clinical outcomes between urban and rural sector. But whether the access and the outcome, poor outcomes are related, obviously it's going to be related, but it's hard to actually show statistical differences. But it's common sense to assume that that is the case. So to summarize it in another way, we have a vicious circle developing or in operation in rural sector. Because of the limited access to specialists locally, the scope of practice remains narrow. And if the scope of practice is narrow, then it's really hard to put business cases for expanding rural workforce because there's not a lot to do. And if there's not a lot to do, then you're not going to have access to specialist services locally. And this means patients need to travel long distances to access their care. So this is where I believe the telehealth comes in. So in my opinion, telehealth models can fill in the gap in situations from symptoms to diagnosis to specialist treatment to follow-up so that people can access the specialist services closer to home. So what is telehealth? I mean, there's a lot of definition of telehealth in the literature, plus many organizations have definitions on telehealth. It's basically using technology to provide your care, but in our clinical situation, I'm talking about providing a specialist service or your care to rural and remote towns using video conferencing technologies. And in this picture is from my office. It's a traditional video conferencing machinery. We have a couple of people in Mount Isa. We are discussing their CT scans, which is on my laptop, and sharing it and discussing it in an interactive or interactive format. So telehealth is really in the literature. It's a big literature, so I didn't want to go into a literature review on the telehealth. But just to show you an example of where that fits in currently. So because I'm a physician, I chose the internal medicine subspecialties first. You could see in neurology, a lot of people do consultations, and also now, especially the German and European models of supervising thrombolysis. And we have seen that the thrombolysis outcomes are similar, whether it is face-to-face or in telehealth situation. Medical oncology, I'm a medical oncologist, so we have supervising chemotherapy through various models in remote towns. Diabetes is really monitoring of diabetes control and consultations. Nephrology, you have even people monitoring dialysis closer to home. And then geriatrics, and this is mainly in geriatrics to keep people in the nursing homes. So there's no limitation to telehealth and the fields. It's really, in my view, it applies to everyone. Everyone who deals with human, it applies, and even radiology, actually, they do deal with humans because they scan people's bodies, so they use telehealth quite a bit. So pediatrics, surgery, mental health, radiology, dermatology, and the list goes on. And also there are many nursing models and allied health models. And one of the things people always ask, especially the surgeons, they will always say, oh, I can't do surgery on telehealth. And I managed to convince many of my surgical colleagues that surgery, operating theater is just one aspect of surgical care. So you can do the operation in the theater, but also remember these days robotic mechanisms. So you could still do telehealth, but I'm not talking about high-end telehealth, the telesurgical technique. But even like consenting a patient before surgery, pre-anesthetic reviews, post-op discharge, post-op wound reviews, you could do the whole thing on video conferencing. So now as a result, the vascular surgeons and the cardiothoracic surgeons actually adopted telehealth for post-operative wound management so that people are not traveling for a 5-minute look of a registrar and say, yep, wound looks good, see you back in 3 months. You can stop that kind of nonsense. So the models of care, I tried to summarize. There's many models, but the 6 models that are quite well known and well established. First one is the telehealth complementing face-to-face and outreach visits. So instead of doing once every 6 months outreach when patients are well, you could actually do telehealth on a weekly basis when the patients really need you, not when it is convenient for the outreach team. Because a lot of the time you find we don't actually diagnose sickness or relapse or recurrences in our outpatient clinics. They're actually in between. So it makes sense to provide your service more frequently so that they get it when they need it. And the second one is the bold model where telehealth really replaced face-to-face care. And that is, the example is really our Townsville Mount Isa model, where there's no specialist travel or patient travel, but the whole medical oncology or chemotherapy services are provided in this manner. And then telehealth for reviews, telehealth for multidisciplinary meetings, and also there are multidisciplinary management models, so I'll come back to them. And then also now we have store and forward models. We have the mobile health, that's the mHealth. Store and forward is really if a GP calls me and say, I got one of your patients, got a rash, I say, take a photo and text me that. That's really the store and forward. So these are the models. And I thought I'll now take you through our Townsville Teleoncology Network as an example of the dimensions of telehealth and the aspects of it. So in the Townsville Teleoncology Network, we have 21 rural sites with Townsville. So initially we had Townsville and Mount Isa. And now because over time the system matured and grew, and the Mount Isa was well resourced to receive and receive the specialist services and provide that closer to home in a comprehensive manner. It has replaced, the teleoncology has replaced the face-to-face. In other sites, there's a mixture of monitoring toxicities of oral medications, managing consultations. That includes communities like Mornington Island. And now we also have some multidisciplinary or remote chemotherapy supervision models in operation where we incorporate telenursing, telemedicine, and telepharmacy. So we have Ingham, Charters Towers, Bowen having chemotherapy units through facilitated by a telehealth model. So this is the multidisciplinary management model I talked about. So the issue with the Mount Isa model was that because it was big enough and they can afford to have, if you're big, you have the volume, and then the volume will justify workforce. So because it is big, we could afford to have 3 chemo-trained nurses. Chemo training means 12 months of dedicated training on chemotherapy and certificates. So that's fine for a large town like that. But that means for smaller towns, if the volume is only 1 or 2 patients a year, then you cannot justify employing a chemo-trained nurse in that place. So that means the those small towns will always miss out and we cannot do chemotherapy. And this is where we developed this model initially as a Townsville telenursing model. So, for example, if this is a rural town, you have a rural generalist medical officers, pharmacists, and general nurses who have a couple of days of training. And then you supervise the whole system. Medical review by medical oncologists, telemedicine, chemo-trained nurses, they now supervise and directly observe and guiding them to finish chemotherapy, so telenursing and the pharmacy. That means selected chemotherapy regimens can be provided closer to home. So fortunately, so we were calling it Townsville telenursing model and then realized it's actually not a telenursing model, it's a remote supervision model. And we used to call it Townsville Remote Chemotherapy Supervision Model, TREX. It was a fancy name. But then when the Queensland Health said, can you develop this model for the state? So we had to work with stakeholders in PA Hospital, Royal Brisbane, and we had to sacrifice the T for a Q. And I'm glad we did that because now the Queensland actually adopted QREX model as the model for small remote chemotherapy supervision. And that means now we have chemotherapy done in V Park, Cooktown, and Atherton by CANS, so they are supervising. And I think the Thursday Island is coming on board very soon. So that's amazing to see actually just by having an adjustment to a mindset and a model, now you can provide your services closer to home. And in Townsville areas, Bowen, Ingham, Charters Towers, and the Cloncurry and Hughenden are coming. So it's nice to be able to ship the specialist services closer to home through these kind of models. So I just summarize in the busy slide from the literature from our service plus the British Columbian models and the Kansas University models. So what I could say is that through teleoncology models or telehealth models, you can provide comprehensive services if you have the governance and the systems and the mindset and the KPIs and the resources right. And it is acceptable to patients and health professionals. It is safe to supervise chemotherapy remotely. It saves money to the health system. And it improves waiting times for rural patients. That means if you can achieve all of them, it also extends rural scope of practice because now rural nurses are doing chemotherapy that they never done it before. And it improves the rural workforce. So now I will elaborate on each of the findings and just shed some light. So the feasibility of comprehensive provision is really, for me, sky is the limit. And as long as we can put governance right, overcome barriers, adequate resources, and integrate telehealth as core business, then you could achieve anything you want. So I need to update this slide better. So we have more than 300 patients. Now the last 100 patients were solely managed by video link from Mount Isa, so that's replaced face-to-face. Urgent cases, all the urgent cases in Mount Isa are treated via video links, so we avoided inter-hospital transfers. More than 100 patients now receive chemotherapy through this model. So it's pretty comprehensive if you want to make it comprehensive. So satisfaction studies, the problem with a lot of the satisfaction studies are you can't do randomized control studies in rural health because the numbers are small. But again, because it's a health service research, honestly, I don't believe in randomized control studies to show that patients like it or not like it. And you just go and ask the patient because it's a small number of patients. Go and ask them if all of them say, or majority of them say, we like it. Then in a democracy, 51-49, you say it's fine. But in fact, this is better than democracy because more than 90% actually say they want these models. And the 10%, you will always have the 10% who are not happy with anything you do. But the 90% of them actually say they don't even want to come to major centers if the service can be provided closer to home. And the main reasons were because it does cut down the travel, and that means patients can be closer to home, doing their farm, doing their day-to-day business without any interruptions. The health professionals like it because it's the first time it's connecting with tertiary centers. Now they have seen the people on their TVs, and now they have friends. They can just pick up the phone call and say, so-and-so, I have a problem, and they can now communicate better. And also it upskills. So they are not limited to their scope of, the scope is now expanded. And also it provides continuity of care. When you transfer someone from tertiary center to Mornington Island, now you can actually hand over on video link so that there is no communication breakdowns. So I now touch on to the cost benefits. There are systematic reviews of pooled studies suggest that the cost benefit is inconclusive. But the problem with this pooling of studies is that they have pooled studies from various countries, third world, first world developing countries, or the second world countries. The other one also, there were a lot of telehealth done in Germany. That is actually, the travel distance is 50 kilometers. I mean, that's really, you can't show cost savings in that 50 kilometers. Because the telehealth is meant for servicing faraway places. You really, if you're going to pool it, you actually need to bring the studies that serve population of, say, more than 300 kilometers or 400 kilometers, and then do it. And we only have 2 studies like that. There is one of the studies from Centre for Online Health from Brisbane, and one of the studies we published in MGA 2 years ago. They do show net savings. So this is the study. So over a 5-year period, the cost of establishing the service was $442,000, and the total savings from the model was $762,000, just from a simple model, but now it has increased. So what we found was from cost-effective studies, the higher the number, higher the volume, higher the savings, and that means in this situation, I think we save about 320-something thousand. So what we were able to do with that 320,000, because that savings was for the Mount Isa Hospital on the patient travel subsidy scheme. So we made sure, because of this, that saving didn't go into the bottom line. We made sure that savings was reinvested into building an oncology service in Mount Isa by employing rotating medical registrar from Cairns. So suddenly now we have a medical registrar in Cairns because we saved the money. So it wasn't extra money, it's actually savings to build rural systems. Teleoncology for Indigenous patients, people used to worry about Indigenous patients and the cultural problems and barriers. But really, having worked in Northern Territory and having grown up in Northern Sri Lanka and having looked after so many Indigenous patients, I honestly never felt that there were cultural barriers. But the only barrier was the health profession, that is, they tried to look at Indigenous as a separate bunch of people and have a separate guideline, rather than thinking it is still a patient-centered care. So every individual is different. So you might have a person like the mundane fellow. His educational level is different. His needs are different, so you talk to them with a different jargon. Whereas someone's educational level is lower, then you change your communication skill to address that person. So what we thought we should really show that through studies, and so we interviewed patients and families, and we didn't find any themes out of the qualitative studies on cultural barriers. The themes were all about proper care, good care, closer to home. It's all about standard of the service we need to provide, and also respecting patient wishes and have good doctor-patient communication skills. So the doctor-patient communication skill was same regardless of ethnicity, in my view. But even in a Caucasian population, you got to be tailoring to individuals. You know, there might be a person from poor educational status. You talk differently, and better educational status, you talk differently. So I come down to a person rather than a culture or groups. And as we said, health workers like this for continuity of care and connecting with larger centers. But also the important aspect of telehealth for Indigenous is that it allows the family members to attend with the patient closer to home. So what happened when they travel to Townsville or Brisbane, they can only take one escort. But in this method, you can have 10 or 15 people. I normally have at least 10 people now in the consultation because they can just walk into Mornington Island Hospital or Palm Island Hospital and see the specialist. So this is an ideal opportunity for embarking on anti-tobacco education and preventive measures. It has other problems, but now we are able to address the families and help the families. So the next question is, I think, safety of remote supervision of chemotherapy. There's always a concern, especially down south, that we might be underdosing people because of the worry about safety. But what we did was we compared the Mount Isa chemotherapy dose intensity, doses, and the toxicity profile and the mortalities, and then we compared with the matched population in Townsville. We found the same dose, the intensities of the doses are the same, and the toxicity profiles are the same, and it gives me and my colleagues the reassurance that you can provide comparable service closer to home through teleoncology models if you have the system right. And it's not dissimilar to the telestroke studies from Germany, where they had the stroke outcomes and the complication of thrombolysis are same. So next one is, yes, it is feasible to provide service closer to home. Yes, it is safe. And then the question can be, what about the waiting list? Because the waiting lists are big, and so we believe that timeliness of access is also important. So before 2007, all patients needed to come to Townsville. That is before the teleoncology service. And then between 2007 and 2009, when we started the teleoncology service, the policy was that the first review had to be in Townsville. So the patient had to come to Townsville for the first review. At the same time, 90% of the Townsville patients were seen within 1 week, whereas the median waiting time for Mount Isa patient was 17 days. That is, 50% of them could attend within 1 week. Even if we wanted to see all of them within 1 week, we couldn't get them here within 1 week because they still have to drop their work, book a flight, and book accommodation, so they couldn't make it. So you could see here 6 patients were transferred, and then 8 patients needed urgent flights, and 43 of them needed standard reviews in that couple of years. So over time, as I said, because we improved the capacity of Mount Isa to provide comprehensive services, in 2009, we were able to make the policy or change the policy that no need for travel. So when that happens, we saw all 11 urgent cases within 24 hours and treated them. And the 54 out of 59 routine clinic referrals were seen within 1 week. That means overall, 93% of the patients were seen within 1 week. So for me, now it is the timeliness is same as what happens in Townsville. And I don't think we could have achieved that without telehealth. So now that takes me to the rural capacity building. So in any agenda to close the gap, my view is that rural capacity need to be improved. The rural sector need to be adequately resourced. Otherwise, all we are doing is bandage care. You just dial in, see a patient, and then dial out, or fly in, see some patients, and fly back. So this is where we worked on. Every time we wanted to grow our service, we made sure the rural sites got some funding. So as a result now, I could say Mount Isa Cancer Care Unit is actually a standalone unit. Only thing they don't have is medical oncologists in town, but the medical oncologist is actually available 24/7 through telehealth, because now Mount Isa is treated as part of Townsville, and now they have allied health, local senior and junior medical officers for oncology, nursing staff. So you can provide comprehensive services like new cases, routine, urgent cases, on demand, that is in between clinics, and treatment of most types of chemotherapy, cancers and chemotherapy regimens and inpatient admissions. So now remember the vicious cycle I showed you before, but now it's not a vicious cycle anymore. It is a positive cycle or virtuous cycle, where by providing local access to specialists via telehealth Now you broaden the scope of practice, and that means you need more nurses or doctors to provide that service or improve rural workforce. That means you are providing more access closer to home. This means you don't need to travel, or the need for travel has significantly decreased. So what I'm trying to do through our Tropical Centre for Telehealth Practice and Research is actually have this principle and make sure whatever we do fits into this framework so that majority of the services can be provided closer to home. And also the next benefit is the professional support and supervision of doctors, nurses, and allied health in rural areas. One of the problems has been the adequacy and the number of supervisors in rural towns, and telesupervision now is a tool now. Unlike the face-to-face model, in telehealth model, every case is a case-based discussion. So you have a patient, there's a doctor, nurse, allied health on the other end, there's a specialist on the other end. It's always a team-based approach. So we are discussing the case as a team, so it's a multidisciplinary care on the spot. We are giving education with the patient, so it is really a telesupervision model. And one of our honors students, she did a qualitative study and identified these 5 themes, and it's impressed with the BMJ Open now. So it does create positive learning environment. It also establishes a learning relationship. It provides stimulus for learning. There's some cost consideration, and also there is some practicalities of telesupervision. That is, examining patient and physical examinations. But again, if you have doctors on the other end, you just voice them while they're examining, so that you don't need to do it. So that's the other benefit of telehealth. So the summary for this bit is, I think there's enough evidence for the place of telehealth models in healthcare, and implementation requires appropriate KPIs and adequate resources. So that's where I go to the next section of it, is how do you integrate telehealth into core businesses of health services, departments and clinicians. And we just got this, the perspective published in yesterday or 2 days ago, MJA, and it really came from talking to a lot of our stakeholders, talking to a lot of our clinicians. It's really simple, but I just got 6 points there. Resources for rural side, it's common sense. And also resources for providing side. But one of the problems has been that tertiary centers always take up the money and keep it with them, but never share it with the rural side. And here, this is where I really make some cautions for managers. That a lot of these activities, if I'm a specialist and I'm now seeing a patient in Townsville, now I'm going to see the same patient on telehealth. For me, I shouldn't be asking for extra money because it's not a new activity for me. It's actually the same activity. I'm just shifting on a telehealth. So only time I should ask for money is if I'm starting a new service that I don't have currently, then obviously I need money. So that's something I think we need to change the mindset of the tertiary centers. And also we have to have KPIs. I don't believe in key performance indicators, but looks like the system needs numbers. So numbers and lines, and so we need to give them something. And one of the things we were pushing in the health sector through statewide is make sure that telehealth is a standing agenda item in all the management committee meetings. So at least it reminds the managers and the clinicians that telehealth is a standing agenda item, and they should be chasing some activities. If the activities are zero, then you should look ashamed. And so you should push the clinicians to increase the uptake. And also now we are pushing, at least in Townsville, because we have a lot of rural patients, the new jobs should reflect, the job description should reflect telehealth teaching and research. So certainly that actually will mean that you'll only employ people who are prepared to do some research, do some teaching, and also look after patients on telehealth. So that seems to be a good mechanism for getting the right people here and also changing our mindset. And then obviously number 4 is clear governance on models, training and quality assurance activities. And the number 5 is really, there are many mechanisms to fund telehealth. There are Medicare funds telehealth, there are state health, they fund telehealth, there's activity-based funding. So instead of going and asking for more money, my philosophy is that we should maximize the revenue first and then see if you can use it, because it's all taxpayers' money. If you're not careful, our tax will increase again. So we really have to go back, maximize the revenue, and then if we need more, then put business cases. The next one is really the important thing is, if there are savings on travel, then they need to reinvest into improving the rural sector. So then always people ask, so how do we establish telehealth models? So my simple advice is, you want to do telehealth, you talk to your admin support and say you're going to book some patient in, call someone on the other end and say, can you be on the other end? And then find the machine and just dial in. That's my advice, but apparently system doesn't work like that. So we put together for the, on behalf of the College of Physicians, I was part of this RACP Telehealth working group, and we put together some tips under practical aspects of telehealth in the Internal Medicine Journal, and really asking those 6 questions and just answering in a succinct manner what you need to do. So first question, are my patients suited to telehealth? I normally tell the people, only you will know whether your patients are suited. Guidelines can't tell you, but my feeling is that every patient is suited if you have the system right. How do I set up? It's about technology. Is it Skype? Is it traditional video conferencing setup? Who should be on the other end? So again, in that setting, if you're doing complex stuff, you need a comprehensive team on the other end. But if you're only talking to people, you just need a Skype and a family member on the other end. So it is really, you got to decide what you want to do. Financial considerations is about maximizing revenue and the establishing cost. Medical legal issues, there's no medical legal issues. There is medical legal issues, but no more than what you will have in face-to-face. The only thing we've been cautioning clinicians is that if you are going to see patients on telehealth, make sure you are seeing the patients in your health, the patient flow area. Because there are some businesses there running out of Melbourne or Sydney, and they will see patients in Alice Springs. But when the patient is sick, they end up in Alice Springs Hospital and probably transferred to Adelaide. So that means you completely upset the continuity of care and upset the flow. So if you are going to do it, what we were asking the clinicians to do it, make sure you have a contingency plan for when patients are sick. So if you want to see from Sydney to Alice Springs, make sure you talk to your physician locally and say, I'm seeing one of your patients here, this is my plan, keep them updated so when they are sick, there's no problem with the continuity of care. That's where the medical, legal, and ethical issues come in. Doctor-patient relationship, I'll just come back to it. And then number 6 is establishing in an institution, really, those papers describe it well, and it's about, again, governance, resources, people. So the last bit on this one is on doctor-patient communication in telehealth. You might think we all do Skype and it's pretty straightforward. We can establish relationships and we do business through Skype with people we never met before, and it works well in that situation. But I feel there is a slight differences in dynamics of interpersonal communication and skills, especially when you have patients involved. And I think it is slightly different, so I'll highlight that. There are many guidelines existing for telehealth consultation, but none of them actually talk about the doctor-patient communication or doctor-patient relationship. So some literature here, not a lot, but some here. There's one group found that on video link of palliative care patients, they can observe facial expressions and emotions. And these are a few of our studies and one of the cancer study. All we did in these studies were patient satisfaction. Satisfaction may not mean they have a good relationship. So we know more than 80% of the people said they have good relationship with the specialist. They can ask questions. They are satisfied with overall care. Same for Indigenous, as I said. And the systematic review from cancers, I think they also found good levels of patient satisfaction, but none of them really asked the hard questions about doctor-patient relationship. So we thought we will explore the doctor-patient communication in detail to formulate an effective framework. So it was a standard qualitative methodology of semi-structured interviews, transcription, coding, thematic analysis, 36 patients and 10 oncologists who took part in Townsville Teleoncology Network. I'll just go into the conclusion in the interest of time. The doctor-patient communication is almost the same as face-to-face and follows the same principles from this study, except for few technology and privacy considerations. So from that study, this is our suggestions or conclusion. So when you do telehealth, be mindful of these factors. First one, be mindful of privacy. That means if the setting is appropriate. When I first started telehealth, no one taught me what to do, and because there's not a lot of people to get advice from. I didn't realize for a few years I was seeing a patient from Queensland in a lunchroom, a staff lunchroom, because the video conference machine was actually in the staff lunchroom, and we always zoom into the patient, so I was talking everything. Only one day I heard someone talking, and I said, "Oh, where is it?" and then zoomed out. Suddenly there were people having lunch, and here I'm doing consultation. So that's unless you actually are mindful of it, you might not realize. So now we say, is the setting appropriate? That means is the door closed on the other end, and it's a soundproof, that area. So that's the privacy issue. And also sometimes you want to know who is in the room, not just the patient, because there may be people, the patient may not want the other people to hear the conversation. So I zoom out and then I ask the patient, you have all these people there, are you happy for us to discuss some serious stuff? And if they said yes, carry on. If they said no, then we ask the people, some of them to leave. That's part of the privacy. The other one, before starting the consultation, that's just technical bits on audio, video. Make sure the picture is in the middle of the screen and zoomed in so that they can see your face and eye contacts and the facial expressions. This is really same as face-to-face. Introduce and greet everyone at receiving and both ends. And also, one of the things we need to do is reassure people that what you are doing on telehealth models is actually as good as what you do in face-to-face. So I had to do that up front. And they used to get consent before, but now I just tell them, this is, if you come to Townsville, this is what you get. So you don't really need to come, and the patient say, oh, that's fantastic, so I don't need to come. And then spend time establishing rapport. That's same for face-to-face. And then, that's if you can do this in telehealth properly, you'll be a better doctor face-to-face, my feeling. And then eye contact and zoom in, zoom out, and also pick up nonverbal communications. So that's really, again, is summarized in that telehealth series paper. So overall, we covered the rationale and the models and how do you establish, and then a bit of advice on communication. So I want to, for all this work over the last 7 years, really couldn't have happened without the help of the telehealth and teleoncology coordinators, and also the Queensland Health statewide telehealth services. They have given us a lot of support. And also, we are now operating under the Tropical Centre for Telehealth Practice and Research under the AITHM. So we are, thanks to the management committee like Rhonda, and there's clinicians and some academics. So clinicians, academic, and our friends, and some of our friends always come to my talk, and I don't know how they are not bored after listening to this for a few months. So thanks again here too for listening, and thanks, Cams, for listening as well. So if you have any question, we can ask, or if you want to go, and we can wrap up and go. So any questions, Cams? it's good. It's pretty straightforward. Anyone here questions?
How important is it that the technology works and you get a wide enough pipe to communicate with your clients, or is the issue of communicating such that everybody puts up with poor bandwidth?
Yeah, I think it's important. There's two aspects. One is, at the moment, telehealth is done by on goodwill basis by clinical champions. So they will put up with anything and then carry on with it because they want to help the patients. But if you want to make it core business and you want to satisfy the average clinician, average means a person who is not passionate about telehealth, but they are forced to do telehealth. And I think for those people, the bandwidth is very important, because even sometimes I get annoyed when the system collapses and everything falls down, and then I'm on the iPhone, the FaceTime doesn't work, and then I'm on another phone. So, it's really upsets people. So bandwidth is important. For high-end stuff like what we do with Mount Isa is really fundamentally important, because there's a lot of dual video systems. You are sharing scans and images. But Queensland Health put in a lot of money into systems, so it's actually a fantastic system. The problem we have is when we go into GP practices, when we have shared care, you rely on the web-based system. So the Skype crashes half the time. So hopefully the NBN will fix some of those issues. Yeah, I think the bandwidth is important. Yeah. All right, so thanks for listening and have a good day.